Dear colleagues and friends, welcome to this wonderful webinar, an important one, Activate Quality in Stroke Care from Measurement to Impact. Just to set up the stage, I would like to quote Sir James Harrington, who said, measurement is the first step that leads to control and eventually to improvement. If you can't measure something, you can't understand it. If you can't understand it, you can't control it. If you can't control it, you can't improve it. So many years ago, we've set up this, and we understand that we need to measure our pathways, our steps, in order to control and to make quality control of what we're doing and to improve it. But the next step, after we do all this, and many of us are using registries, you have to also to implement what you have learned and what you improved, and then to see the outcome, the impact. So today we go from measurement to impact. As you can see on the screen, we have an excellent panel of speakers, world-renowned stroke neurologists, and also dealing with measurements and impact and quality controls. So without further ado, I'll introduce the first speaker, but before, there was no chat available for us today, so everybody should, if you have any questions at the end of all the speakers, at the end of the session, you will be able to put your question in the Q&A, and we'll try to do them all or to try to find the best that we can about it. So these are the overview of the agenda, as you can see here, and why measurement matter, data action and global examples from different parts of the world, from Philippines, South Africa, Colombia, and Czech Republic. But let's start with our first speaker, who does not need any introduction, my dear friend and Professor Robert Mikulik. He's the chair of neurology in the Regional Hospital Zlin and director of stroke research program in St. Anne's University Hospital in Brno, Czech Republic. He's the founder of the Rescue that you all familiar with, and principal investigator of the EU-funded Rescue Plus project. Robert, the podium is yours, please. Try to keep it in time.
Nathan, thank you very much. I will be in time, I promise. So, hello everybody from Zlín, Czech Republic. So I will try to persuade you why quality monitoring is important, and I will explain it on the learning health system, and then I will briefly talk about randomized and non-randomized clinical trials that use the quality monitoring as one of the intervention. And I will conclude with the guidelines, how the current guidelines are presenting the quality monitoring. So the learning health system, the definition is that it's a healthcare environment where internal data, sorry, I will need to minimize my window here, and patient experiences are continuously analyzed and fed back into clinical practice to improve care quality, safety, and outcomes. So basically, we know that our clinical management is driven by the evidence, right? So the evidence is here, and the evidence is translated into the guidelines. But we also know that the compliance with the guidelines differs. So even after 30 years of thrombolysis in clinical practice, it's still not fully implemented. And in many countries, it's not available at all, right? So it takes a lot of time to implement, evidence and the guidelines. So how do we do it? Well, we need to transform the guidelines into some data model, which basically quantitatively tell us how we perform. So how do we know how we perform? well, we need to benchmark our performance against something, right? And the best way is to benchmark against other hospitals, because not all the treatments needs to be necessarily provided to 100% of patients. And this is because, there are certain indications and contraindications which are limiting the provision of the treatment. And there is also a certain social economical factor in which hospitals operate. So to identify how we perform, you need to compare it to something which is comparable, right? And these are the other hospitals. So once we benchmark our hospital against the other hospitals, then we see the gaps of the quality of the provision of the care, right? Once we identify the gaps, then we need to figure out how to remove it. And there are several quality improvement interventions that were tested, such as the establishing of the leadership, training and education, development of clinical pathways, action plans, checklists, quality monitoring to identify barriers and the gaps, and continuous monitoring and the feedback. And these interventions were tested. We have, for example, 2 randomized clinical trials coming from China. In this study, they randomized patients to the intervention and no intervention. And the intervention was establishing the communication between the clinicians and the quality improvement team, education, awarding, and the quality monitoring. And you see that it modestly improved number of the patients that received thrombolysis, intravenous thrombolysis with dortoneal time within 60 minutes. Another hospital from China, again, randomized study, which used the quality coordinators to analyze the gaps in the quality, establish the quality monitoring and provision of the feedback to the clinicians. And it nearly doubled the access to intravenous thrombolysis. It also substantially improved the treatment of atrial fibrillation with the anticoagulation. We have many non-randomized studies, such as this one from Australia, where they look at the financial incentives, outreach visit, and the feedback on hospital performance as the intervention. And they compared these hospitals under the intervention with the historical controls, also with the other hospitals in Australia. And you see that the odds of being treated in the stroke unit, receiving thrombolysis, and having a care plan after discharge was improved by 50, 12, and 60%. We have also a lot of data from the United States, where there is one of the oldest quality improvement program, which is called Get With The Guidelines. And it shows that the hospitals that are participating in this quality improvement program, which of course includes not only quality monitoring, but many other things, then the access to the TPA was improved, and following was improved, screen, and lipid management was improved. We have data recent from Poland, where they documented that quality monitoring using rescue decreased the door to needle time. And we have basically the same thing from Czech Republic, where we actually collect all cases treated in thrombolysis for, since we started in 2004, so basically for more than 20 years. And this is the door to needle time of all patients in Czech Republic. And it was substantially decreased from nearly 70 minutes to 20 minutes in 2018, and it's around 20 minutes since then. And basically, there were 2 most important interventions, which was the education and quality monitoring and the feedback. We have also the evidence from the German quality registry, which nicely documents that hospitals that are compliant with the quality indicators have much better outcomes. The patients in these hospitals have much better outcomes. So if the hospitals are compliant with the quality, then the 7 days in hospital mortality was very low as compared to the hospitals where the compliance was much less. And you see that the difference in the mortality was actually very, very striking. So it's a nice evidence that really that measuring the quality and compliance with the quality is really important. So taking all this evidence together, if you look at the most recent 2026 American Heart and Stroke Association guidelines, it says that hospitals treating patients with acute stroke should engage in multi-component QI process that involves the continuous monitoring, review feedback of stroke quality indicators, benchmarks, and evidence-based practices in order to increase the quality of care, improve patient outcome, and reduce healthcare disparities. And hospitals treating patients with acute stroke should participate in stroke data registries to increase the adherence to quality indicators and guideline recommendations and improve patient outcomes. So basically, the quality monitoring is again, it was already in the previous guidelines. Now it's again in these guidelines, of course. And it basically says that quality monitoring should be the part of our routine care. It's nothing like extra. It really should be embedded in our basically daily routine. So I hope that I persuaded you that the quality monitoring is important. And microphone back to you, Nathan. You're muted. Nathan, you are muted.
I'm sorry. Thank you very much, Robert. And move on to the next speaker with Rupal Sedani. I think that's all everybody knows. Rupal, she is a global certified lead of the WSO and International Strategic Partnership of Rescue. And she'll talk about using Rescue to support quality improvement. Rupal, please.
Yes. Thank you, Dr. Nathan. I hope you can hear me clearly. So taking up from the topic Dr. Mikulik just shared, I will briefly focus on tools like Rescue, which can help you to support the quality improvement work in your hospitals. And Dr. Nathan already quoted this very important quote, which I believe very strongly as well, that definitely measurement is the first step that leads to control and to improvement. So now we know the importance of quality monitoring, but the challenge what we all have is mainly about the structured data that we have, or we are able to compare this kind of data, what we collect, and then use it into our routine clinical practice. And that is what we will be talking about. And the role of registries come in picture here, because you take up any database, the data what you collect, this data can be used for various purposes and by different stakeholders. When we look at the physicians could use this data for improving their stroke management in the hospital, because once they are able to see the gaps, identify the gaps, they are able to fix that problems much faster. When it comes to the professional stroke societies, they can issue the guidelines, they can provide evidence-based information, and also it helps to define the benchmark. In some countries, even the insurance companies use this data for providing financial incentives for the evidence-based treatment to the hospitals. And with the Ministry of Health, this data definitely can be used for regulating the stroke management in the country or improving the stroke services in the country. So you can see the impact of the data, what gets collected or gets monitored. It can be used by every stakeholder in different ways and for various purposes, because ultimately everybody is working towards improving the healthcare. And that's where Rescue is. Rescue, as you know, it's one of the largest international quality improvement tool for stroke. It is operated in 94 countries by more than 2,600 hospitals so far, and with 1.3 million plus patient cases of all stroke type. So this has been one of the largest quality improvement tool used by various hospitals, public as well as the private setup. What Rescue does is it collects mainly the entire stroke pathway, the structured indicators, right from the patient arriving to the hospital till the patient is discharged from the hospital. And it also allows you to capture the 3 months follow-up outcomes. What makes, well, of course, there are several registries in place, but what makes Rescue unique is the harmonized data collection form. You have a harmonized, standardized data collection form. It is built on a secure GDPR compliant platform. Very important that it is aligned with the various certification programs run by WSO, ESO, as well as American Heart and Stroke Association. It's also aligned with the evaluation, serves as an evaluation portal for the ESO WSO Angels Award program. Plus, more importantly, what Rescue provides to you is the real-time feedback and benchmarking. So this is very important in the form of dashboards, in the form of reports, the ready-to-use PowerPoint reports, as well as the raw data, which you can use for various purposes in your hospital. Furthermore, this data actually can be used it can be also integrated with various national registries, or if you already have any hospital database in place. So it's not just, there are different ways in which you could use the data. One is, of course, you directly use Rescue platform and collect the data there and monitor the performance. Secondly, you can also use the data, you can integrate with the national registries via the bulk data import, which is the REST API in technical terms. And this basically prevents you from duplicating your efforts in data collection. And whereas once you share the data with Rescue through this bulk data import, you are able to access the dashboards and the reports as well as the benchmarking, and you are part of the entire offerings which Rescue offers. The important topic, I think one of the challenge which we all face when it comes to data is about the data security and compliance. Again, reaffirming that Rescue is built on a GDPR compliant platform. The hospital retains the ownership of the data and the control of the data here, and what the data comes on Rescue is the patient level data, which is anonymized and securely stored. And this data is primarily used, of course, for quality improvement and benchmarking purposes only. That's why this effort, as you can see, we run this campaign called as Activate Quality from Measurement to Impact. This is a joint global effort between Rescue as well as the international stroke organizations. The effort is to improve the quality of data what we collect across the world so that we are able to use this data in a more meaningful way. So although, of course, quality monitoring has to be part of the routine clinical practice, but importantly, March and September are the two dedicated months where we encourage all the hospitals around the world to collect all consecutive stroke cases into Rescue. Because what we do with this data is not just collect this data, but also we built this kind of a structured report, which basically shows you the insights on various parameters of the quality monitoring in stroke. As you can see, we could show you the trends in the treatment time, as well as you can see the arrival mode to the hospital, what is the percentage of EMS pre-notification in different countries. You can also see the post-acute care, the swallow screening performed, etc. So many such reports are published, and these have been disseminated by European Stroke as well as World Stroke Organization. So this is how we use the data. So it's important that it's not just collecting the data, but then using it, where you can identify the gaps and thereby, use it for improvement. We continue our efforts in advancing the tool of Rescue with Rescue Plus kind of projects. It's an EU-funded project. We are mainly working on two main objectives. We're trying to automate this whole process of audit and feedback, by building these tools, and also building a clinical virtual assistant tool which can help the doctors to, quickly identify the gaps without really getting into the data into the system. Second, most important, I think across the world, we face this challenge of the follow-up with the patient. We are building a patient virtual assistant tool for life after stroke. And this tool will definitely help all the patients around to monitor their progress once they are discharged from the hospital. The information will flow back to the physician, thereby improving the follow-up rate. So as you can see, the tool actually helps you to monitor what you're doing on a real-time basis, plus also in future, it will further strengthen the quality monitoring system. So to summarize, I would say that let us not reinvent the wheel by building new registries or building the new platforms. Very important for us is to, to make quality monitoring part of routine clinical practice because, as you say, as you believe that what gets measured gets improved. So thank you very much for your attention.
Thank you so much, Subal, for introducing the excellent rescue and all the advances and the news about the rescue. And I hope that many other people will join, many other hospitals will join the rescue and to continue collecting this data is so important. So now we are going to the second part of our webinar. It's the part which will show us example for different countries how the rescue was conducted and implemented and how this changed actually the clinical practice. So the first one is Professor Epifania Colantes from the Philippines. And she is talking about using data strengthens stroke care in the Philippines. Epi, the floor is yours. Who is changing the slides?
Yes.
Are you with us?
Okay.
Good.
Yes.
Okay, perfect. Go ahead.
Okay. So this presentation is about the Philippine rescue data, how it strengthened and improved our stroke care. I will focus on trends over time, the key improvements, the persistent gaps, and how the data is guiding system-level quality improvement. If you can't measure, you cannot change. So we really need data. So I'll discuss the change of quality measures during the first 5 years. 2020 to 2025, the improvement in reperfusion rates and the change in the patient's outcome. This is the map of the Philippines. And you know, the participation of rescue expands from Luzon, Visayas, and Mindanao. And this expanding coverage has been critical in understanding our national patterns and our regional inequalities in stroke care. So these were the quality measures in rescue. It assessed from early assessment, the diagnosis, the reperfusion therapy, admission to stroke units, including rehabilitation and prevention. The Philippines has about 90 acute stroke-ready hospitals, and these are certified by the Stroke Society of the Philippines. But these are mostly concentrated in the big centers, and you can see in the periphery, there's no access to acute stroke care. So there's really a great inequity in stroke care in our country. So comparing during the past 5 years, 2020, only 84 hospitals participated, but in 2025, 113 participated. And the mean age of our stroke patients are quite young, less than 60, compared to other countries. And cerebral infarcts is the most common, about 60%. And ICH is about 20 to 25%. But note that in 2020, there's increased rate of ICH about 32% because of uncontrolled hypertension. And during the first few years, only the centers in Metro Manila, the National Capital Region, and Northern Mindanao participated. But now there's a good distribution of the regions with the data. So we don't have EMS in 2020, but now some regions have EMS, 34 and 32%. But our risk factors remains uncontrolled. 70% of our stroke patients have hypertension in 2020, and it even increased to 73% in 2025. The same with diabetes, 18% in 2020, and it even increased to 25% in 2025. The AF detection was low in 2020, but it increased to about 15 to 20% during the following years. So the lacunar stroke is the most common in 42%, followed by the large artery atherosclerosis. And you can see here 30% high rate of cardioembolic strokes in 2020, but it has gradually declined to 21% because of the use of NOACs, because we have now the generic and cheaper, more affordable NOACs. So in 2020, most of the patients were admitted in the standard bed, 65%, but it has gradually improved, and most of the patients are now admitted in the mixed ICU stroke unit, 58%. So imaging, now there's a mixture of CT and MRI. Door-to imaging has also improved from 84 minutes to 25 minutes. Door-to needle has also improved from 55 minutes to 41 minutes. Even the IV thrombolysis from 7% it is now much improved to 17%. So in 2020, we were only using Altiplase, but now there's a gradual shift to Tenetic Place. In 2025, 12% were using Tenetic Place and only 88% Altiplase. So this is our greatest gap because we have limited number of thrombectomy centers, so we have limited access to thrombectomy. So the cases are still low, 21 cases in 2025 for the entire country. And you can see the door-to-groin time is also a bit long, but it has gradually improved, but this is still high. So swallowing assessment has also improved from 83% to 95%. And anticoagulant use has also improved from 51% to 88%. And but this is also long. The onset of stroke to the ER door, previously the mean is 7 hours. It has gradually declined to 270 minutes or 4 hours, but we really need a lot of community awareness. But the discharge MRS has improved from 3 to 1. Even the NIHSS, and this is for cerebral infarction. So the reasons for no thrombolysis is because a lot of patients come into the ER beyond the time window, 68%. So for the ICH, you can see here in 2020, the mean volume was 10 cc, but it has increased to 28 to and in 2025, 27 cc, because a lot of patients have this uncontrolled hypertension, and these are usually from the public hospitals wherein the poor patients cannot afford the antihypertensive medications. But the control of BP has now improved. Systolic BP less than 140, 21% in 2020, but it has improved to 81% in 2025. And even the discharge MRS for ICH has improved also to MRS3. So hypertension remains the most common modifiable risk factors. Next is diabetes mellitus. And age of stroke onset is younger compared with other countries, and more ICH in public hospitals compared to private hospitals. And there's a high incidence of AF, 20%. The most common classification of infarction is lacunar stroke in 40%. And there's a lot of missed opportunities for reperfusion therapy because of delayed hospital arrival. And majority of patients are admitted in standard beds in 2020, but it has now improved. The national thrombolysis rate is 17%. The door-to-needle time has improved 45 minutes, but the thrombectomy cases has not improved. The median MRS score has also improved, even the MRS for ICH, because these are patients with large ICH. So limitations, there's no data on 3-month follow-up, no data on rehabilitation. We have a lot of missing data, and not all stroke patients are included in the database. Although we have acute stroke-ready hospitals certified by the Stroke Society of the Philippines, we are now preparing for the WSO stroke unit certification. And we have started the Philippine Telestroke. The Philippine General Hospital has set up and collaborated and is providing training for our first telestroke network. So these are the quality of improvement, the key areas: increasing community awareness and strengthening the EMS services, training non-neurologists, increasing access to thrombectomy service, utilizing technology or telestroke and improving our rescue data, the quality of data, and also upgrading insurance coverage for stroke treatment. It's really a rescue to our rescue. So rescue continues to be a powerful tool for measuring progress, identifying our gaps, and guiding our national strategies to improve the stroke care in the Philippines. Thank you.
Thank you very much, Ebis. Very impressive progression that you are doing and expanding the rescue and improving the quality control of all the parameters in the Philippines, and hopefully we'll see more and more improvement in the next few years. So our next speaker is from South Africa, Dr. Louis Kroon. He's a vascular neurologist and Stephen Biko Academic Hospital in South Africa and lecturer at the University of Pretoria. Louis, please.
Thank you, Prof. Bornstein. It's a nice, kind introduction. So I just want to say hello to everyone, and it's a great pleasure to be here today and to share with you the experience I've had in setting up our stroke unit at the Biko Academic Hospital, as well as what the practical implementation of quality control meant to us. So I'm first going to start off with a little bit of a background of stroke in South Africa. So as we all know, stroke is one of the leading causes of mortality worldwide. From the 1990s to 2016, the stroke incidence in low to middle income countries have doubled, in contrast to a decline of 42% in higher income countries over the same period of time. Evidence shows that Africa could have nearly a threefold higher rate of stroke incidence when compared to that of Western Europe or the United States. So as of 2021, there are only 150 neurologists in South Africa, serving a population of 58 million. 35 of these are working in the public sector and the remaining 115 in private. It is also important to note that approximately 85% of our population is using the public healthcare system. So as you might know, there's a large income disparity in our population. We have a rough estimate of 40% unemployment rate, and this leads to a large amount of people living below the poverty line. This disparity is also evident in our healthcare system. On the left, you can see a typical public provincial hospital, and on the right, it's a picture of one of our private hospitals. So the hospital where I'm situated is an academic hospital with 950 beds. It's directly serving a population of 4 million in the district of Tshwane, which you can see on the screen here. We also are the academic referral center for both the Limpopo and Mpumalanga provinces, bringing the total referral population to approximately 14 million people. Just to highlight the mortality of burdens of cerebrovascular diseases in South Africa. And this is a nice table that was published in Stats SA. And as we can see, vascular diseases account for the second highest impact of morbidity rate in South Africa, just next to infectious diseases. And when we look at the subcategories, cerebrovascular incidents account for the fourth highest cause of mortality. And with this, I would like to start off with this quote by William Wordsworth, who said, "Life is divided into three terms, that which was, which is, and which will be. Let us learn from the past to profit by the present, and from the present to live better in the future." And this is basically the foundation for quality improvement. So in 2021, we conducted a prospective study on stroke management, analyzing the risk factors and treatment in 140 patients. Notably, 30% of these patients arrived within 9 hours of stroke onset, while only 15% presented within the 4.5-hour time window. Despite this, none of these patients received a reperfusion, with unpublished data showing daughter imaging times exceeding 8 hours in most of these cases. And this was a similar article that was published in the South African Journal of Radiology, done by another academic center in South Africa. And their findings were similar to our institute, which demonstrated the median daughter imaging times were about 8 hours, since the patient was first identified as being a stroke in the triaging area. So, as we have just seen, the American Stroke Guidelines strongly support quality monitoring, giving a Class 1 recommendation for having a standardized measurements to enable long-term performance analysis. And this data can then be used to identify the gaps in stroke care, allowing targeted interventions to address these disparities. And from this, we can see that we needed to participate in a quality improvement registry in order to measure our performances so that we can identify the disparities in order to provide improved patient outcomes. Based on this, we optimized our stroke pathway, designed to simplify door-to-needle times more effectively in accordance to these quality indicators. This video on the bottom of the screen is what Steve Biko looks like, and only 15% of our patients actually arrive with EMS services. So we know that we have to optimize our stroke pathway for patient walk-ins. So upon entering the hospital, we have a stroke cart that is located next to the entrance of the triaging area. This helps to record patient arrival times, activating the stroke code, and simplifying the process for getting the patients prepared as they walk in to the hospital. It is equipped with a couple of telestroke cameras, an augmented reality headset, point-of-care INR analyzers, iPads, and a couple of stroke applications, specifically for activating and recording the time. We then have a green line, which is approximately 50 meters long, leading to the CT scanner. Patients are not allowed to deviate from this line. We perform advanced neuroimaging on all of our stroke patients because a lot of these times patients have an unknown onset of stroke time. These patients then move into our stroke unit, which is equipped with iPads, LED smart lights, as well as Holter monitors for telemetry. This area also serves as reference points for the interdisciplinary team to make contact, as well as quality monitoring to take place here. It is a very important aspect of our stroke unit is to allow these quality indicators to serve as active points of communication between the different teams. And we use various methods to achieve this. For instance, as the patients are admitted into the unit, we record that a swallow assessment has been done and what the outcome is. And this is based upon, we then communicate this information over based upon different colored LED smart lights. And this is based upon the IDDSI system. It is essential that our whole team work together so the data gets captured on a live system. It then keeps the whole team updated, and this ensures that none of the patients fall through the cracks. Then lastly, providing positive feedback to the whole emergency team who manage these patients are also critical. Having an active quality monitoring system as well as dashboards help with some healthy competition. We have a nice scoring board in the ED demonstrating the door-to-needle times and their records. So at this time, our record door-to-needle time is 8 minutes. So this leads to another famous quote that defines quality improvement and systems thinking as a holistic approach, focusing on the interconnectedness rather than its isolated components. It emphasizes understanding the root causes over time. So by implementing a quality improvement registry is a form of systems thinking where actual patient data serves multiple purposes. The outcomes that we have experienced on our side by doing this ranges us from publications to improving patient care by, for instance, allowing us to improve stroke management. For instance, retrospectively looking back at the number of patients that were diagnosed with atrial fibrillation and which of those patients were treated with anticoagulation, and then closing this gap by the discharge medication improvement sheets. It also allows for professional bodies or societies to improve guidelines on the current performances and shortcomings of the country. It also provides financial incentives for evidence-based treatments, like the admissions of patients into stroke unit care or treatment cover for IV thrombolysis or clot retrieving devices. We, for instance, managed to get full sponsorships for additional specialist training due to the large shortage of specialists that we have in our country. It also helps with government regulation policies, and then it allows data to get distributed back to the WSO, ESO in order to help influence organizations like the World Health Organization to assist with PMB recommendations. Eventually, all of these factors improve the stroke healthcare back to the patient again. And that concludes my talk. Thank you.
Thank you so much. It's using all this advanced technology to improve stroke care and improve your quality pathways. It's really very impressive. I think that we should learn from you guys how to do it. And I think that's the point. Teamwork is the main important point. The multidisciplinary team that talk to each other, not in isolation. Thank you so much. And without further ado, Claudio Jimenez from Bogota, Colombia, is with us, I hope. Yes, and he's a neurologist, neurophysiologist based in Bogota. He's actively involved in stroke research and international initiatives, including Angels. So we'd love to hear what you have to say, Claudio, please.
Okay, Thank you, Nathan. Thank you, Rupal, for inviting me to share with you this space. And I'm going to talk a little about the improvement in Latin America process of certification of stroke centers, but how really we using rescue have changed the reality of our places. So if you look at the rescue platform, one of the things that you could think is that maybe rescue is the thing that unify more Latin America, even more than football. You have 3 or 4 different confederations of football, soccer in Latin America, but with rescue you could see all the countries in just one site. That's something that I thought recently while I was preparing this presentation. If you can see, we have a lot of centers doing the register. We recently achieved the 100 centers certified in Latin America. The growth of the centers that do the register is very amazing, and the certified centers that we have each year since the last 5 years is just marvelous. But how we get to do this, I'm going just to show you the example of Colombia particularly. We have all the biggest cities in our country are in the Andean region, and we have there the cities with the best human development and the richest cities in our country. So how you use some tool like Rescue Register to improve the quality of care, not only in this kind of places, but in a so diverse and disparity country. We did a work with just like all of you have said, with the Ministry of Health, with the Secretaries of Health of every one of the states of Colombia that conform Colombia. And recently in 2024, we launched this national cooperation strategy between the World Stroke Organization and the Ministry of Health that has helped us to involve more centers in different regions of Colombia, using rescue and using the process of certification of WSO to get a better access to treatment. And these places have to do the measure of what they are doing. Here we are with the actual Ministry of Health of Colombia and the Secretary of Health of Bogota, which is the biggest city in Colombia. And we certify a particular way of facilitating the access to stroke care in Colombia. There is a public-private strategy that let the patients go from one place to another into our health system. What we have done, and this I believe is one of the best things that we have achieved, is try to decentralize the access to stroke care, not only in this Andean region. We choose different places in the rural area of Colombia and the poorest regions of the country, and try to select hospitals and make them the principal hub of attention for different cities, small cities, and all of them in the rural area of the country. So we create this stroke network that is called the Ariari Stroke Network. I'm going to show you some pictures. And this hospital, Granada, controls the access of stroke to every one of these places. We here have nowadays access to thrombolysis and mechanical thrombectomy. These have been done because of the National Cooperation Plan. The Hospital of Granada measure the quality of care using rescue and is in the path to become a certified stroke center. Just for you to see, this is the Andean region of Colombia. It is Bogota, Medellin, and all the richest cities of country. But as you get out from there, you have here Granada. Down there is the Amazonian region. And these blue spots are the different small cities that they cover as a stroke network. Just to tell you that 1 year ago, the patients in all this area didn't have access to stroke care and quality stroke care. We recently we start to create a WhatsApp stroke code. We activate the code. give all the data that we need to capture after the attention and do the stroke care register in rescue. Here is the patient that we did the first mechanical thrombectomy in this region. So you have to train all these people to make them understand that we need to do what you have talking about. We need to measure. We don't need just to attend somebody. We need to measure everything that we do. We need to measure the times. We need to measure the door to needle time. And the particularity of this man that I'm showing to you here is he lives here. This is the place where he lives. Puerto Rico Meta is one of these villages that is covered in a rural stroke network. They don't have to come to Bogota. Usually, these patients that live in these kind of places, they have to wait 2 or 3 days after suffering the stroke to arrive to a place like Bogota when there's nothing to do for them. So the fact that we want to measure, that we want to teach these people, these physicians in these kind of places, the importance of measuring everything that they do in terms of quality of care for the patients suffering a stroke, let us create this kind of stroke rural networks that we are developing here. And people from these kind of places are now receiving the access not only to thrombolysis or mechanical thrombectomy, but to centers involved with the importance of the register. So this hub Granada in this rural stroke setting is the first hospital of this kind that is going to be certified by the program of stroke centers of World Stroke Organization, because they are doing this quality of stroke care register using rescue. So we measure, obviously, like every one of us, not only the whole amount of patients that suffer a stroke, the patients who receive thrombolysis, the patients who get access to mechanical thrombectomy. We measure our door to needle time like everybody else does. This is the things that we are trying to improve in every setting of Colombia, not only in the biggest city, as I have told you, but in this kind of environments like these rural areas. And we try to maintain the standard of care, obviously, in every place that we go. In this rural region, we do the same thing that we did in Bogota. We create a public partnership to give access for the patients in this public-private partnership for access to stroke care. We started in 2021 in Bogota, and we measured the amount of patients that are accepted, those who are not accepted, but we persist over time. Nowadays, nearly 100% of patients in this kind of strategies that need access to stroke care, especially mechanical thrombectomy, that are receiving private clinics or hospitals. And we obviously measure why they are not accepted, and that's what led us progress over time, and at the end have a better stroke network because of the registry of quality and the improvement in all these challenges that we have to resolve. We did our own microeconomics, let's say, a study, knowing why all these people, which is the amount of money that we need to spend taking care of the patients in the hospital setting. This let us understand that one of the things that we need is not only the access to thrombolysis or thrombectomy, but we need teams of care. We need phonoaudiologists. We know that one of the things that increase the spending in the care of patients with a stroke is that the teams usually don't have phonoaudiologists. These people suffer from pneumonia because of bronchoaspiration. So the teams get better when you measure, because you know which are the things that are complicating the good outcomes of these patients. And one of the things that is a worse outcome is the pneumonia associated with bronchoaspiration. So we have now phonoaudiologists, and in all these settings that we are working in the cities and in the rural area using rescue, we can give information to the hospitals to not only have access to the medicines, to the thrombolytics, or the procedures like thrombectomy, but the human talent that we need to take care of this kind of people. Recently, we received a visit for the certification of a stroke rehabilitation center in Bogota. Now in Latin America, we have more than one certified stroke centers. One of the things that I always said that for me is pretty important, and I think that is one of the messages that we need to pass to the people, is that this is not the work that one person does. The quality of care and the improvement in the registry of quality of care has a lot to see with the creation of a partnership with our leaders and our mentors, like Sheila Martins. She has visited every one of our countries in Latin America. Here she is with the Ministry of Health in Colombia, teaching us and helping us how to create this national stroke plan. And we have hundreds of colleagues and friends in the whole region working with this inspirational message of quality of care. Well, that's what I have to say.
You're on mute, Dr. Nathan.
Yes, I just want to say that it's very impressive how you actually expand your activities to the rural area and try to improve quality of care at that particular region. So congratulations. So last but not least, we have with us Professor Aleš Tomek from Prague, Czech Republic. Aleš is very active. Everybody knows him. He's currently serves as a co-chair of the Stroke Action Plan. He's a professor of neurology and also the chair of the Cerebrovascular Comprehensive Stroke Center in Prague. So Aleš, we're looking forward to hear what you have to say, how to improve the quality of care in Czech Republic, who is one of the best, probably, stroke care around the world, as far as I know.
Thank you, Nathan, and welcome everyone. I'm really happy to be there. It's my first time taking part in some World Stroke Organization webinar, and I'm really happy about it. So I would like to show you our experience that is going back maybe 25 years with quality measurement. Robert Mikulik, who is my friend, and he's part of our Stroke Society here in Czech Republic, has shown you something, and I will show you more details, how to basically move from measuring to implementation and to getting better care. So Czech Republic is a small country. It's only 10.5 million, so it's like basically like a city in Philippines or Colombia, or maybe even less. And we had 22,000 strokes usually per year. We have a big advantage that our healthcare system has mandatory health insurance. It's free at the point of delivery. Basically, it means that patients are not paying anything directly, and everyone needs to be insured. So there is no problems with private or public. The network is open to everyone, and you basically cannot go anywhere else. So I would like to show you how we get there, and this is what I'm showing. It's looking pretty busy, but it's basically key performance indicators that were defined by European Stroke Action Plan, and there is 20 of them. And as you can see, Czech Republic is at the 4th place, basically the same number as Netherlands, only Norway and Austria are better. And I would like to show you how we got there. So first, what do we monitor? We use Rescue because Robert, as founder of Rescue, is from Czech Republic and it started here. So Rescue is compulsory by Ministry of Health decree. So basically, if you are treating stroke patients, you need to put things in Rescue. It is compulsory for all patients only 2 months a year, like WSO now does, because it's pretty difficult for us physicians to put all the patients in, as you know. So we do it for everyone, 2 months a year. but we do it to every patient who has thrombolysis, thrombectomy, and now also intracerebral hemorrhage. So those patients are put there, every one of them, whole year. Then we use, because this is not telling us the whole story, we do use data from reimbursement companies because everyone is insured, so we have the data of everyone. And now we've started using data from ambulance cars because they do collect GPS coordinates where the stroke happened and all the times when they pick up the patient, when they arrive with the patient. So we then put it into the maps and look at where is the best place to be treated. So we do collect structural indicators. We certify stroke units every 5 years. And then we, every year, do annual indicators. We have 24 quality performance indicators based on rescue and reimbursement companies, and it's all assessed by Ministry of Health. And then every month, every chief of stroke unit will get an email from our Stroke Society and Angels telling him indicators for the whole month. And then we do now triage of pre-hospital times every 3 months. So how it works, basically, as you can see, the physicians and insurance companies all can propose a quality indicator. Then there is a commission in Ministry of Health where there are people from scientific organizations, insurance companies, and they all basically govern the stroke care. We meet, a couple times a year and we look at the data. And then what does ministry do? They write laws. So they put out decrees, basically a law that says, patient with fast positive should go to stroke unit and the percentage of thrombolysis should be this and that. So what is the motivation in the system? Of course, it's legal to do it. Then there is a higher reimbursement from insurance companies if you are in a stroke unit, which is certified. Of course, you look better when you have nicer numbers. And what's negative motivation? Of course, it's a loss of certification that you basically cannot continue to treat the stroke care. So just to show you about structural indicators, structural indicators are basically the number of beds that you need. You see that primary stroke center should have 8 beds of neuro ICU, 30 beds of neurology, 30 beds of early rehabilitation, and it has to have at least 4 vascular neurologists. So we looked, so how we do organize our system. We always look at the data, and we noticed 5 years ago that when you go into primary center, you have much better chance of survival than if you are in a hospital without neurology. So we then implemented it into our system. So what it meant, basically we try to concentrate the patients because as you see, there is more than 150 hospitals in Czech Republic that are doing acute care, but only 55 are certified for stroke. So the ambulance needs to go to the stroke unit. So now when the network is already functioning, we look at the data before the new accreditation comes every 5 years, and we see the red dots on the map. So where the patients are not coming 100% to the stroke centers. So what we did, we expanded our network and we made the patient to go, we basically tried the hospitals in this area to start a stroke unit. So what about IVT rates? Just a little bit fast, we, I think, have the highest IVT rate in the country, in the world currently. It's nearly 37% of all patients that get thrombolysis. And our national DNT is 3 years in a row, 20 minutes, the median. So how we do it? We measure all the times and we get every month the data back. We look at it and we try to do simulations. So that's how the monitoring looks like. You can see that we started with those monthly emails in 2016. So it's now 10 years that we are doing it every month. And you see now there are hospitals with median dot to needle in all patients, 11 minutes. So it's got pretty good, I would say. We also look, how to get there. So we also try to measure, like you go directly to CT or not, or what basically things you need to do to reach those numbers. We do lots of simulations in our centers, which really help us to make shorter DNT. And and many else. So you can see here just one curve, door to needle 70 minutes. When we started to accredit stroke units 15 years ago, then annual reports, then monthly reports, and we basically got there when you measure it frequently. What we also noticed, the bigger the center is, the faster they reached the times, which is expected. But smaller centers, in the end, have the same DNT as the big university hospitals. And the last thing I want to say, we, up to this month, we just showed those data and numbers only to us physicians and politicians. But now our Ministry of Health, you can see me here with him, they started to basically to put it on a public web page, and every patient can look at their hospital and see what are the real numbers every year. So I think this is the last, and that's how it looks like, what the patient can see, his or her hospital, what's the mortality, what's the modified ranking at discharge, and basically everything is public. And believe me, in last month, I had to reply to at least 10 journalists why this hospital is basically so bad, why this hospital is so good. And everyone is really, I think, getting better now because they are under pressure from the public. So just to conclude, I think you need to have organized system in the whole country, use the ambulances, and especially measure the quality, make it fully public, and look at your results and try to adjust it accordingly. Thank you very much.
Thank you very much. Oops. Thank you so much for sharing your experience and how you improved the stroke care in the Czech Republic. It's very impressive, and we all know that you're doing an excellent work and continue to improve. We have to learn from your experience and to implement it in many other countries. I don't see, there is probably just one real question in the chat. It's about telemedicine, how to implement telemedicine according to the WHO guidelines and recommendation. The question is whether do we have time for that? Lara?
Yes, go ahead.
Okay, so who would like to take the question, how to implement or to build up telemedicine in stroke care in the country? This is, the question is coming from Iman Najimi.
So I think, yeah, Claudia and Epifania, they have the telemedicine.
You've talked about.
So you know, we have a geographically isolated areas. We have 7,100 islands, so that we have the apex center or the hub, and we have a MOA with the different hospitals, and then we communicate initially through the Join app. But now it has become very expensive for us, so we're just using the Viber. But we need to establish communication, collaborate. We have to have a MOA. We have to train these spoke hospitals. Thank you.
Thank you, Epi. There's another question here in the chat. This is regarding how do you think we should measure the longer-term outcomes and rehabilitation? Alish, maybe you can take it.
Yeah, I think, usually everyone measures 3 months. So it's a key to see the patient at 3 months, because then this is the time where the real effect of stroke, if you are treated or not, will take place. So that's key. And how to measure rehabilitation, it's quite, I would say, quite different in every country. But what I would recommend, we have started with it, is to measure at least at first the quantity. It means how many stroke patients will get the rehabilitation, and not just physiotherapy, but measure separately speech and swallowing. and measure also ergotherapy separately. And when you have those measurements, you can look how it's different in between your hospitals and try to aim at the best of the hospitals in the system. And then what about the quality? What we are doing, we basically measure the modified Rankin and Bartel score in the beginning of the rehabilitation stay and at the end of the rehabilitation stay. And we do the simple comparisons if the functional outcome of the patient is getting better in this rehabilitation hospital. Basically, what we have shown, there are big differences. Some hospitals tend to have much better scores in the end than in the beginning than others. So I think you can start simply by implementing this simple quantity measurement in the beginning.
Actually, I just would like to mention that the SAPI and especially the ISO East are
Yes.
currently trying. We know that the rehabilitation is the weakening link, and we try to improve the connection between the acute stroke and the rehab. And we are currently conducting a survey among all the hospitals participating in the ISO East in order to try to find, first of all, to measure how many going to rehabilitation, how many center where, what are the quality in this, and then we'll try to improve it. So this is a very good point. And the last but not least is another question. I think that is for you, Alish. I would like to know about your data harvesting system. How do you manage to have consistent and continuous data? Thank you.
So it's basically what we have made a rule that there needs to be a stroke quality coordinator, a special person in every center, which is basically needed to be paid by hospital. So this person's job is only to coordinate the data collection. So that's one thing. The second thing is, of course, there are all of us are people, so it's not possible now to use rescue for all patients. So we do put together the data from insurance companies, they have every patient, and rescue. And we try to combine those. For example, the number of patients, when we count the thrombolysis rate, we take all the data from all patients from insurance companies, and then in rescue we see the real data like door-to-needle times and so on. So I think that's one way. And I think the better way will be what is Robert and rescue working on, and that is basically AI reading your hospital discharge papers in the future and putting the data into the rescue. So I think the Rescue Plus in near future will solve this problem for everyone.
Great. So I think if there's no further questions, it was a pleasure and to be chairing this excellent webinar with a very excellent talks and speakers. And I hope that you have learned a lot and you take a lot of the messages back home to implement it in your own hospital. So with this note, I would like to wish you a very good evening, morning, wherever you are in the world, and all the very best. Thank you for inviting me to share this wonderful webinar.
Thank you. Thank
Thank
you,
you.
everyone.
Bye, guys.
Thank you.
Bye-bye.
Bye.
Bye-bye.
Bye-bye.